Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, ladies and gentlemen. In the beginning, I would like to thank Dr. Mahdi for his kind and warm invitation to give me the opportunity to talk to you today about aeromedical disposition of aircrew with ischemic or coronary artery disease and cardiac arrest in the sky. Before we get through, I would like to shed some light on human factors on aviation. Most of us knows that about 70 to 80% of fatal air accidents are due to human factors. This is because of the inevitable human limitation and formation of man-machine complex. Human factors is the study of human performance and limitation in a complex environment. It is a marriage of psychology and engineering. The relation between man and machine has a constant coefficient, which is error generation. This error is existing since life was created. This is an example of man-machine complex. On the right side, we see two human beings completely bound to the machine, with numerous pieces of information are being processed all at the same time, and only one correct response has to be taken. In the left picture, we see another very complex area: anesthesia, ICU, CCU, emergency room. It's all complex area. In fact, about 80% of fatal outcomes in anesthesia is due to human factors as well. Therefore, anesthesiologists, they look closely to aviation medicine and they produce their own checklist, pre-induction, during induction, and post-induction. The aircraft is complex, but the human body and the human physiology, when deranged, and when the human body is attached to numerous number of machine, intra-aortic balloon, LVADs, pacemaker, infusion pumps, and etc. So very complicated areas. Of the 70 to 80% human error in aviation, lack of ground proximity awareness occupies the top of the list. We know that about the critical phases of the flight is the takeoff, the final approach, and the landing. You need to count about 20 minutes from the rolling of the aircraft and about 45 minutes from the initial descent. Therefore, 80% of air accidents occur only during the 4% that the aircraft is spent near the ground. On the bottom of the list, medical incapacitation, less than 1%, and it has to be kept below 1%. If medical incapacitation would exceed 1%, the pilot is going to be permanently grounded. Therefore, in aviation practice, we have a very huge rule called the 1% rule. It is a risk assessment or risk threshold assessment that is applied to the pilot medical fitness. In simple terms, the rule of 1% states that in a multi-crew operation aircraft, the percentage of sudden incapacitation of a pilot who is suffering from pre-existing medical condition should not exceed 1% annually. It was actually formulated in 1984 by the Joint Aviation Authorities of the UK and European Safety Aviation And regarding coronary artery disease, it says On reaching the age of 63, an average male has a cardiovascular mortality rate that is approaches 1%. Nowadays, the age is 65. Another example of the rule of 1%. The percentage of sudden incapacitation from malignancy is measured by the likelihood of the tumor to metastasize to the brain. In case of carcinoma of the ampulla obvator after 5 years excision, the rate of brain mets is less than 1% and the pilot can fly. Coronary artery disease in aircrew is not a frequent cause of sudden incapacitation. In fact, the most frequent is gastroenteritis, 60%, compared to 0.6 chest pain. Paradoxically, coronary artery disease in aircrew is responsible for 45% of permanent grounding of professional civilian pilots and about 20% of restricted flying. As we all know, acute coronary events, half of the cases is silent, and more than the half of the silent cases is catastrophic, ending up in myocardial infarction or death of the patient. Those who have symptoms are the luckiest. Silent coronary artery disease has two important implications. Aeromedically, which is related to the risk of an acute coronary event and its impact on the flight safety, passenger and aerospace. The other one is clinical. That is to say, what secondary preventive strategies can be taken to modify the progressive nature of the disease. We know that the risk is not only related to the degree of stenosis, but also to the extent of the disease. An acute coronary event can be precipitated by occlusion of a pre-existing stenosis, but fissuring of the endothelium over soft erythematous unstable plaque will lead to platelet aggregation and formation of thrombus. The more extensive the disease, the more likely is the presence of numerous soft unstable plaques. There's no sound. Okay, this is a flight had a sudden cardiac arrest on board. The flight was going from Seattle, and there was a sudden cardiac arrest. Okay, for the pilot. This is in February 15, 2012. Captain of the Czech Airlines arrested and died in a flight from Warsaw to Prague. The one-man cockpit was able to bring the aircraft safely to the ground in one piece. Captain Ajay Kukurija, 43 years Indian pilot of the Qatar Airways, arrested and died in a flight from Manila to Doha. The one-man cockpit was able to bring the flight down or divert to Singapore. 60 years old captain of Continental Airlines arrested in a flight from Brussels to New York and died mid-air, and the first officer was able to bring the flight down to the ground in one piece. Malaysian 370. What had happened? Could it be two cockpit incapacitation at the same time? We don't know, but a study in 2004 by the FAA Aerospace Civil Institute from 93 to 98, there was total of 50 cases of pilot medical incapacitation in 47 flights, 39 total aircrew incapacitation, and 11 partial or impaired, like they were able to do some flying duties. Now from 47 flights, the two members were affected in 3 of these flights, and 4 ended in death due to cardiac arrest. in 7 flights, the safety were seriously affected. Therefore, the probability that an in-flight medical event of the cockpit that can cause an air accident is 2 out of 50. That is 0.04%. The FAA records in 1986 showed that about 1/3 of professional civilian pilots lost their licenses due to coronary artery disease. The Korean War subjects post-mortem showed evidence of coronary artery disease in about 70% of the subject, and about 10 to 15 had a significant lesion, more than 50. In the Vietnam War also, about 45 of the subjects post-mortem showed evidence of coronary artery disease, and the mean age was 22. And there is a strong evidence from this that the process of atherosclerosis starts at an earlier age. In the First World War, 60% of aviation casualties were due to defect in the aviators, medical defect. 20% of aviation casualties were due to enemy action. Therefore, in February 28, 1927, the Department of Commerce and the Aeronautical Branch published the first 57 aviation physician names. Now, new generation combat aircraft with their ability to expose air crew to high and different degree of G-forces, they place a high demand on the cardiovascular system. So a significant ischemia may result due to pooling of blood circulation to the periphery. Significant ischemia may result. So a small lesion in the ground may not be so in air. Aeromedically significant disease is defined as a left main stem lesion or more than 30 proximal LAD, more than 50% luminal obstruction in any of the major vessels, 2 or more lesions of more than 30% in a major vessel, and extensive disease, with lesion not exceeding 30 to 50%. Now, some organizations like US Air Force, they use this scheme of adding lesion between 30 and 50% to identify a burden of acceptance of atheromatous disease. Passengers also, they have a lethal cocktail, flying stress, the need to reach the gate, reach the airport, circadian rhythm dyschronosis, and the cabin environment, low oxygen tension, humidity, all this is a lethal cocktail. Now, passenger cardiac arrest is not also a frequent cause of death in the aircraft, but it is not common cause in the aircraft. But 1,000 deaths annually. We have about 2 billion passengers traveling annually. This number exceeds the number of from deaths of 27 crashes that occurred in 2006. That was about 863. So the chances to survive from cardiac arrest for a previously healthy individual before is less than 10%, and the chance to die in an airline accident is 1 in 4.7 million. Now, before 1990, the standard practice of airline was to divert the aircraft to the nearest major airports whenever they have a cardiac arrest on board. Taking into consideration, it will take about 20 minutes to make an emergency landing and about 10 to 15 minutes to reach the gate. No one of these passengers survived. Because as we know that successful reversion from ventricular fibrillation is dependent on time-sensitive defibrillation. Now, the first CPR program was an AED was implemented by the Qantas Airlines, and it was started on 1991. In June 30, 1996, the Chicago Tribune published an investigative report called Code Blue Survival in the Sky, and shows that the number of deaths in U.S. airliner, all the airliners, was 316 annually. Therefore, in 1997, early they implemented the AED, and CPR program by the American Airlines was implemented. This resulted in saving about 80 lives until 2011, and training of 18,000 of crew members, and they were awarded the Heart of Gold from the American Heart Association. In CPR in the sky is a cardiac arrest in the sky, just like in the ground. About 70% of patients arrest in ventricular fibrillation and can be treated successfully with electrical defibrillation with long-term survival rate of 30%. Now, for every minute of delay from the time of collapse to the time of defibrillation, survival rate decreases by 7 to 10%, and incorrectly performed bystander CPR will reduce also survival rate by 3 to 4%. The most important factor is early recognition of cardiac arrest by the cabin crew. Today we have 5 medical equipments on board: the AED, the doctor emergency kit. These 2 are no-go item. Then we have the first aid kit and the UBK, which is used to control the secretions of the patient, the ill passengers. And recently implemented by Saudi Airlines, the CDK, contiguous disease kit, upon encountering the recent MERS-CoV. The doctor emergency kit is also a no-go item, and it's opened only by doctors on board due to the presence of controlled medication. Thank you so much.